I invite Dr. Harshad to speak on pregnancy-related acute liver failure.
I would like to thank Dr. Kesa for the opportunity to present some data on acute liver failure and pregnancy. Most of it, but the data I will be presenting is from our own series, which have been published and are still in the form of publication. So in liver diseases in pregnancy, you divide them into three groups, and one is coincidental liver diseases or chronic liver diseases, and third group, which I'll be predominantly talking about, is liver diseases which are unique to pregnancy. In coincidental liver diseases, it's just like any other individual, the pregnant lady gets the infection. It could be herpes simplex or any viral hepatitis, gallstones, malaria, typhoid, and that any individual is exposed to. In chronic is the patient has a chronic disease, hepatitis B, C, Wilson's, and becomes pregnant. And the third category is liver diseases which are unique to pregnancy. And these include hyperemesis gravidarum, intrahepatic cholestasis of pregnancy. But the diseases that are most deadly are preeclampsia, HELP syndrome, and acute fatty liver of pregnancy. Now again, you can divide them into whether the diseases occur within the first trimester, second trimester, or third trimester. And these are all coincidental diseases which occur in the first and the second trimester. But strangely, most of these diseases which are unique to pregnancy occur in the third trimester, and we'll discuss this a little later. So in a pregnant lady whom you encounter with ALF, the issue is whether it's an acute or chronic liver disease, or whether it's an acute viral hepatitis, or are drugs or toxins responsible? Is Budd-Chiari syndrome a possibility? Or are these liver diseases which are unique to pregnancy? Now, clinicians have always tried to separate and distinguish pregnancy-specific diseases into AFLP, HELP syndrome, and preeclampsia liver diseases with clear borders. But in reality, there's tremendous overlap both with clinical features as well as biochemical features. Now that's why once you see a patient, it becomes very difficult for you to distinguish them into whether they have AFLP, HELP, or preeclampsia. And we'll see that a little later. And this is the reason why. You'll find that there's a tremendous overlap. Look at this for platelets. It can be low, normal, it's low. Fibrinogen low, increase. But look at this. Glucose can be low. Also, it is low in severe diseases. Creatinine is high. Ammonia is high. Again, can be high. Very rarely it is normal. And CT scan, only in the last stages do you see fatty liver of pregnancy. Now again, if you come to AST and ALT, which we rely on, you'll find that there's again a tremendous overlap. AST, ALT 10 times in AFLP, 10 to 100 times with HELP, and viral hepatitis again 10 to 10 times. Again, if you have a patient, let's say of about 400, AST of 400, ALT of 400, then you really do not know whether it's AFLP, HELP, or preeclampsia associated liver diseases. Now, with pregnancy-specific liver diseases, it contributes to 0.6 to 5% of all causes of fulminant hepatic failure in the Western series. Now, in the acute liver failure study group, which presented a little earlier, it contributed to only 0.8%, or 11 patients out of 1,321. Pretty rare. It was 5% in the King's College Hospital criteria, as well as it was 10% in our study, which was published 4 years ago. And this is the study where we distinguished between patients who presented with acute liver failure as well as those who presented with acute viral hepatitis. Now you find that most patients who presented with acute liver failure or pregnancy-specific liver disease had encephalopathy, SITs, as well as almost 41% of them died. Subsequently, with a review of analysis of the last 3 or 4 years, we have brought down this death rate from 41% to about 14%. Now, in another series published from California, they had 8 patients who underwent liver transplant for what looked like HELP syndrome. But look at the MELD score, 40, and 40 is pretty high. And I'll come to our series of MELD score. Encephalopathy, 7 out of 8 patients, renal failure 4. So basically, by the time this patient presents to you, present to you in a very advanced state of liver disease. Now, this is the patient we encountered just 1 month ago, a 20-year-old primary gravida, 35 weeks of gestation. She presented with anorexia, nausea, epigastric pain of 3 days duration, mild jaundice, tachycardia, and blood pressure which was normal. She was drowsy but well oriented. She presented to the emergency at around 4:20 in the afternoon, and because of fetal distress, she was straight away shifted to the OT and delivered within 45 minutes. The bilirubin 14, AST 107, ALT 179, alkaline phosphatase obviously elevated. Hemoglobin 11.4, increased leukocytes, platelet count 1.14. So see, if you see a gynecologist, then they probably call this as HELP syndrome because of low platelets. But look at the glucose. Glucose is 68, and it was very difficult to keep the glucose in control. INR of 3.4. Ultrasonography suggested coarse liver, spleen 10, and mild ascites. Now this patient, again, soon after delivery, she delivered, of course. And once you see such a patient, it could be either HELP syndrome, AFLP, or preeclampsia associated liver disease, even though this patient did not have preeclampsia. Now, despite extensive resuscitation, the patient died 5 days later. And this is, you can see the liver biopsy post-mortem. The liver cells stuffed with fats. You can see there's almost 90% of the liver cells were stuffed with fat. And most of this fat is in the pericentral area, very few in the periportal areas. Now, so in acute fatty liver of pregnancy, there's extensive infiltration of fat. The hepatic failure, encephalopathy, and hypoglycemia is very common. You have abnormal prothrombin time, and there's a tremendous overlap between the other diseases as I mentioned to you. And you also have oliguric renal failure, and the patient had a creatinine of 6.4. Now, we presented this in the May issue of last year, and that most patients with pregnancy-specific liver disease actually have ascites. And the problem arises, do these patients already have concomitant chronic liver disease, or is ascites a feature of acute pregnancy-specific liver diseases? And as you can see, ascites occurs in 76% of women in these patients. It is transient, has all the characteristic features of portal hypertension. And then almost half of the patients with ascites also have spontaneous bacterial peritonitis. Fortunately for these patients, it does not affect mortality, even though disease severity is pretty high. Now, this was an oral presentation at the ASLD 1.5 years ago. And this is a series of over 11 years, 130 patients, and we distinguished them into alive as well as dead. And you find that patients there was no difference between patients who survived and patients who died with regard to age, abdominal pain. But then patients who died already had presented with increased severity or increased encephalopathy, oliguria, ascites, and at most half the patients had intrauterine death. Again, biochemical variables don't help you much, except that serum creatinine obviously is very high in those who died. But platelets are less in those who died, and sugars tended to be low in those who died. Now, again, coming to a very important finding, and that is the AST and ALT does not help you distinguish between any of these diseases. But then serum proteins and albumin are low in patients who died. Total bilirubin, alkaline phosphatase, INR, as well as the MELD score. Look at the MELD score, 32.5 in those who died, and 18.2 in those who survived. Now, this is in print, but I just put this figure just 15 minutes before this presentation. And that notice that even though the MELD score is just 10 to 19, you already have a mortality which is creeping up 6.9. With a MELD score of 20 to 29, it's almost 1/4 of patients die. So MELD score is a very good indicator, a prognostic factor indicator for distinguishing patients who will survive and who will die. But you can't have the MELD score of 31.5 or even 35. And you should not wait till you have such a high MELD score for prognosticating such patients. Now, in the last presentation at the ASLD, someone just rightly asked me, he said, you had 24% of deaths. How come you have 24% of patients who died with pregnancy-specific liver diseases? I tried to tell them that over the years, the pregnancy and mortality has decreased. But then I was very, very happy to see this published last year. And this is from the King's College group of over 50 or 60 patients. You find that almost 20 patients, 7 patients, 13 plus died, 4 at 7%. That's 20 out of these patients. That's almost 21% of their patients also died and some of them required liver transplantation, suggesting that some patients, even in our series, are apt candidates for liver transplantation if you can diagnose them earlier. Now, how do we manage these patients? Of course, we have to, as I mentioned to you, you have to deliver them pretty fast. The mother's life is the most important criteria. You don't wait for the baby to grow. You have to save the mother at all costs. You have intensive supportive care, orthotopic liver transplantation. And again, once you have delivered, your duty is not over. You have to screen all these newborn baby for LChat deficiency, and come to this a little later. The second disease that mimics very closely HELP syndrome, again, the treatment is the same, that you need to stabilize this patient, deliver them pretty fast, and then if they become bad, then you have to really send them towards transplantation. If I want to leave this hall with one concept, and that is the concept of fatty acid transport and metabolism, mitochondrial oxidation, and then that is that these fatty acids are abnormal or metabolized in a very abnormal way in patients with pregnancy-specific diseases. I won't go through this slide except to suggest that any of these enzymes can be blocked or in low quantities or mutated, giving rise to fatty acid metabolic disorders. And these are acute fatty liver of pregnancy and HELP syndrome. They are now considered as fat mode disorders. Now what happens in these patients is that fatty acids and all these metabolites get accumulated in the liver cells. They are not metabolized, and because these are toxic, they produce all the manifestations that you can see in HELP syndrome and fatty acid disorders. Now, the symptoms that you see in patients with acute fatty liver of pregnancy HELP syndrome are exactly the same symptoms that you see in LChat deficiency, and they are listed here. Now, you have hypoglycemia, you have Reye's syndrome, hypoglycemia, hyperammonemia, increased transaminases, brain edema, fatty liver, you have hepatomegaly, lactic acidosis, you have intrauterine growth retardation, prematurity, cholestasis, exactly the same features. So it's most of these patients have some form of fat mode disorders, and that is why you need to screen both the babies as well as the mother for these disorders. Now, this is a fascinating concept, and that is most inborn errors of metabolism. The mother is a carrier, and the fetus can be affected, but it can be of benefit. Whereas the most classic inborn error of metabolism is phenylketonuria. And here you notice that the mother is affected and the baby is a carrier, but it produces a lot of harm to the baby. The baby invariably dies unless you treat the mother. But look at these fat mode disorders, that's acute fatty liver of pregnancy as well as HELP disorders. It is the fetus who is the culprit. The fetus is homozygous for all this LCR deficiency, and it produces all the toxins which enters the mother's circulation and produce harm to the mother. So it is imperative that you save the mother at all costs. And once you have saved the mother, then you go back to the baby and screen them for LCR deficiency, because these patients throughout their lifespan are at increased risk for sudden death. So whenever you see any patient with maternal complications of pregnancy, including ALF, think of LCR deficiency. Now the common topic that was discussed just a few minutes ago, there's acute viral hepatitis, ALF in pregnancy. And I'll start off with the case that we saw about a year ago. This is 27-year-old lady, fever of 3 days, 32nd week of gestation, no medicines, examination, 39 degrees temperature, somnolent, doubtful jaundice, labs 3600 ALT, 5600 AST, bilirubin just mild, 2.2, INR 1.9. The following day, she's still febrile, somnolent, ALT still high, ultrasound negative, and this is the biopsy. And this biopsy shows, as you can see, multiple herpes nuclear inclusions. And unless you do a biopsy, that's another indication for biopsy in patients whom you suspect that these patients can have herpes. Very rarely do you have clinical markers or cutaneous markers of herpes, but then unless you treat this patient for herpes, and that treatment is very simple, you are going to lose the mother. So liver disease in pregnancy due to herpes hepatitis, that 23% of herpes hepatitis is reported in pregnancy, 23%, and that's very high. Often diagnosis and condition does not improve following delivery. You can't wait till delivery. You have to make the diagnosis clinically before the mother delivers and treat, but regardless of whether you want to wait for the diagnostic information or lab reports to come or not. Now, liver disease, third trimester, it usually occurs in the third trimester of pregnancy. Viral prodrome is seen in only a few percent of patients. High transaminase, the clue is that the transaminase is very high, but no jaundice and coagulopathy and encephalopathy. So again, treatment is very simple. You give acyclovir, give it for 14 days, and then you see a marked recovery. Now, most of it has been dealt with recently. I'll just briefly mention, I'm running out of time. Why does hepatitis E virus infection lead to severe disease? We really do not know. There could be host factors, hormonal factors, immunological factors, and virological factors. Now, the issues with regard to pregnancy is whether the pregnant women are more susceptible to hepatitis, whether pregnant women with viral hepatitis more often progress to ALF, and whether ALF during pregnancy has a worse prognosis. Now, you find that pregnancy increases the risk of contracting hepatitis and its severity, including ALF. And then you can see in all these epidemic settings, in all these series, that you find that pregnant ladies are not only prone but also have high mortality. But these are epidemic series. Now, the next question, pregnant women more prone to viral hepatitis, there are certain caveats. Again, as I mentioned, all these are epidemic settings. There's some disparity between academic and sporadic.